the people are coming in.
Yeah.
We wait another 1 to 2 minutes to allow time for people to come in.
Wow.
Whoever is already in, we just give some more time for more people to come in. The number is still going up, so we wait until it stops before we officially start the webinar. Okay, numbers are stagnating now. I think it's time to start. There will be more people to come in later during the webinar. But to everybody, welcome to this webinar of the EANS spine section, which we have today. I think it's the 9th webinar in a row we have now. And as always, this webinar is going to be recorded and will be stored and be available on the webpage of the EANS Academy, where already is a very nice collection of webinars, presentations. So whenever you haven't looked at the EANS Academy, do so, and you're going to find presentations to any of your specific questions. But for tonight, I'm very happy to have here with me as presenter Mark Bilski from New York, Memorial Sloan Kettering Cancer Center. I think there's no need to say a lot of things, but I will do so anyway. So Mark Bilski was trained in New York at New York Hospital, Cornell Medical Center, before he then left to focus on tumor treatment for the Memorial Sloan Kettering Cancer Center across the road. He's there now in the present position as William E. Snee Endowed Chair, Vice Chairman, Clinical Affairs, Neurosurgery, and Chief of the Multidisciplinary Spine Tumor Service. And that's his main interest. Spinal oncology. He's interested in metastatic and primary malignant spine tumors, benign spine tumors, all aspects, whether it's spinal, intradural, extramedullary, or intramedullary tumors. He's one of the well-known experts. He coined specific things like the NOMS framework for decision-making in spinal metastatic disease. And another one term which is connected to him is the term of separation surgery. And I'm very happy to have him here tonight to give a presentation on the concept of separation surgery in metastatic spine disease. So after the presentation, we'll have some time for questions and answers. And as always, please type in your questions in the chat box or the Q&A box. And later on, we're going to discuss those points after the presentation. So thank you, Mark, for being here. Thanks for having me here. And I'm looking forward to your presentation on separation surgery in spinal metastatic disease.
Florian, thank you so much for the gracious introduction and the invitation. I am incredibly grateful to be here and share our experience over the last, oh God, now going on almost 30 years, which is hard to believe, but real. What I'm going to try to talk about today is how separation surgery fits into the framework of the NOMS decision tree. And this has really been a work in evolution since the inception of our group, this multidisciplinary group, which is now almost 20 years old, and really been a very powerful project in the institution in terms of delivering very expeditious patient care to a very needy population. And then from that really grew out a lot of academic productivity, because everything we wanted to look at was sort of new and different with the integration of radiosurgery, and then trying to minimize the surgical approach to reduce morbidity and still be incredibly effective for this population. As many of you know, metastatic disease, spine metastases is an enormous problem in the cancer population. Up to 20% of patients develop spine metastases, and we've definitely seen an increased number over the past 10 to 15 years, partly as an ascertainment issue that MR and FDG PET have improved detection, but also these newer systemic treatments have improved survival. And while the biologic checkpoint inhibitors are incredibly effective for visceral disease, they're definitely less effective for bone disease. So we think we're going to see a continued uptick in the number of tumors that we're responsible for. Despite this improved survival with these systemic agents, the goal of therapy for metastatic spine tumors remains largely palliative. Want to improve or maintain neurologic function, achieve local tumor control, mechanical stability, pain relief, and ultimately improve quality of life. And if we get this kind of outcome, this patient who had an instrumented thoracolumbar burst fracture, pathologic burst fracture fixed, who's doing this 100-mile paddle on the Allegheny River, we've clearly met that goal of palliation versus this patient who not only had failed fixation, but a radiation recall burn on the back requiring extension of his hardware and then a free flap reconstruction. In the primary tumor population, this is a really bad outcome. In the metastatic population, this is unforgivable. And so everything we've done in the past 20 years or so is to mitigate this kind of outcome and get patients back to systemic therapy early and then back to a good quality of life. Far and away, the greatest advance hasn't really been on the surgical side, but it's been the integration of stereotactic radiosurgery. It's defined as high dose per fraction conformal radiation, often given as 16 to 24 gray single fraction or 8 to 10 gray times 3 fractions. And compared to conventional external beam radiation, that sort of point and shoot radiation, typically given as 3 gray times 10 fractions, radiosurgery obviously has a shorter treatment time, but you can actually give an ablative cytotoxic tumoral dose. And that fundamentally changed our treatment paradigms, including the indications for and type of surgery that we do. There have been major advances in radiosurgery, including technological, defining tumoricidal doses and dose constraints for organs at risk, and even defining the radiobiology of radiosurgery. Now, much of our need to sort of integrate more therapy in terms of the spine metastasis actually was predicated on my first real experience in cancer, which was that I did the anterior skull-based malignancies at Memorial for about 25 years. And what became very clear in a tumor like this that involves the orbit, maxillary sinus, and then extends into the infratemporal fossa was that you could be as aggressive as you wanted with a surgery, and you still weren't going to meet the goals of cure because there's a microscopic disease outside that gross tumor volume. And it's very hard to overcome this really aggressive biology tumors with surgery alone. And so this was the curve that really changed things for me, I think largely was, again, it didn't matter whether you en bloc to try to get margins into these massively disfiguring operations. At the end of the day, the only thing that really mattered was the tumor histology. And in point of fact, you can't overcome bad biology with really aggressive surgery. And most of our metastatic tumors fall into these categories of these really high-grade, very aggressive tumors with a big microscopic penumbra outside the gross tumor volume that you simply can't account for no matter how aggressive you are with your surgical approach. Now, there are times where we do en bloc resection still, where we have evidence that it actually makes a difference. Certainly for superior sulcus tumors, Pancoast tumors, neoadjuvant chemoradiation improves survival from 15 to 60%. So if you gave neoadjuvant chemoradiation and then did an en bloc resection, we significantly improved outcomes. If we can prove that we can do chemoradiation and not do an en bloc, we will not do these surgeries anymore. But at least at present, we continue to do it for tumors like this, and we do it for a tumor like this, which is an osteogenic sarcoma that got neoadjuvant chemoradiation and then en bloc resection. What you don't see in this is chordoma, and I'm going to show you how we started to integrate radiation into the chordoma paradigm that may again allow us to do less aggressive surgery for patients who require it, rather than trying to do massive en bloc with loss of bowel and bladder and disfiguring operations. We may have the ability to integrate really effective therapy, particularly radiation, into that treatment paradigm and begin to change the aggressiveness of the surgery, again, to overcome a bad biology tumor with a big microscopic penumbra that even with the most aggressive en bloc surgery, we're not really doing a good job at getting control of those tumors. You can see in our multidisciplinary spine tumor service, we started this in 2007. There were 3 of us, myself, Josh Yamada, who's really the father of spine radiosurgery, and Eric Liss, who is perhaps the best interventionalist in spine tumors in the world. But what got bigger by necessity was really the radiation component. It really has gotten massively big. And if you look at the numbers treated in 2020, we did a little over 2,400 radiosurgery target treatments, and the surgeries were only 400. So we're 6 times bigger on on using radiosurgery as opposed to surgery. Surgery still has a really meaningful role, which we'll talk about. But ultimately, that separation surgery, where we're doing an epidural decompression for neurologic salvage, represents only 5% of the treatments that we offer this population in a given year. So here's a typical case example of a 66-year-old male, has a history of renal cell carcinoma, has biologic back pain that is severe, and his acute onset of weakness is an ASIA-C. His other issues, right? He's got chronic renal insufficiency. His stomach workup showed renal cell extending into the renal vein and some pulmonary nodules. And you can see this really high-grade circumferential disease at T10. And I think if you look at this history in the radiographs, it's kind of hard to put this picture together. They have lots of issues going on. They're neurologically impaired and they're sick in other ways. And so many years ago, we came up with what's known as the NOMS decision framework. And really what we're trying to do is pull out the 4 sentinel decision points that you need to make to decide best treatment. And those decision points are neurologic, oncologic, mechanical stability, and systemic disease. And what's very powerful about NOMS is we've always left it as a decision framework as opposed to an algorithm, because we wanted to integrate evidence-based medicine as it became available and newer technologies. In terms of the newer technologies, it's really been exponential in the last 20 years. If you look at where we started around 2000, there were very limited options for therapy. And we have now evolved incredibly effective agents in every domain of systemic radiation and surgery. And certainly for us, the major focus has been on integrating SBRTs, stereotactic radiosurgery, and this concept of separation surgery in the metastatic population, again, to reduce morbidity and get more durable tumor control than even with more aggressive surgery. So how does NOMS work? The neurologic and oncologic considerations are made in combination. From a neurologic perspective, we're very concerned about whether the patient has myelopathy, functional radiculopathy, but much of the decision-making is based on the degree of epidural spinal cord compression. And there's a scoring system that's been validated where 0 is bone only, 1A, B, and C are different degrees of epidural impingement without spinal cord compression. 2 is spinal cord compression, but CSF is seen. 3 spinal cord compression, no CSF seen. And for decision-making purposes, the 2s and 3s are considered to be high-grade cord compression. From an oncologic perspective, what we're really talking about is how we achieve local tumor control. And at least to us, tumor control is completely predicated on radiation responses, and radiosensitivity has been completely redefined as we've transitioned from conventional external beam radiation to stereotactic radiosurgery. And much of our talk will be on the neurologic oncologic integration of stereotactic radiosurgery. There are other modalities that we use. We have P32 plaques, beta emitting radioisotopes to clear dural margins, and then occasionally we'll use high dose iridium afterloaded catheters for recurrent bone disease. Mechanical instability is a separate assessment, right? Because no amount of radiation will stabilize an unstable spine. The SINS criteria, as you all know, was developed to define instability in the neoplastic setting. There are 6 components to SINS, and all are weighted by their contribution to stability. So junctional and mobile spine have a higher point score than semi-rigid or rigid spine. That pain, yes, is movement-related pain, axial load type pain. Bone lesions are classified as lytic mixed or blastic. Alignment, subluxation, translation has the highest point score. The degree of vertebral body collapse or involvement and whether the posterior elements are involved, bilateral, unilateral, none. Again, weighted by their contribution to instability. 0 to 6 is stable, 7 to 12 potentially unstable, and greater than 13 unstable. Here's that very classic patient who has thoracolumbar burst fracture with significant movement-related pain. And these are often the ones that come into that indeterminate category with a SINS 10. And those are very good candidates for percutaneous cement augmentation, either vertebrokyphoplasty. And there is class 1 evidence from the CAFE study that patients who undergo kyphoplasty do significantly better in pain relief, both at a month and durable out to a year compared to best medical management. So while it is somewhat controversial in the osteoporotic literature in the cancer population, it is a very effective modality to get them over pain very quickly and again, improve quality of life. What we found is that patients who get into that grossly unstable category where they have a burst or compression fracture with extension into a posterior element and the joint. You can't do simple standalone kyphoplasty and put cement into the vertebral body. They actually need a posterior tension band. And so for these patients, again, with a burst or compression fracture with a joint involved, we'll very often do kyphoplasty at the index level and then back them up with percutaneous PMMA augmented pedicle screws to build a tension band across the posterior elements. And that really gives them significant and durable relief. And in our series of 46 patients, again, most of these patients had severe pain, and with percutaneous pedicle screws and cement augmentation at the index level, we go to mild or no pain in the postoperative period. And then there are the patients like this, as you know, who have significant fracture subluxations. This patient has significant greater than 5 millimeter fracture subluxation at C1, C2, where we don't have effective percutaneous procedures, at least at present. And this patient needed an open decompression and then occipital cervical fixation to provide stability across the OC junction. And so these patients still require open surgery for instability. And the last assessment, right, is you've made this neurologic, oncologic, mechanical stability is what makes sense in the context of the disease. Are they too sick for anything that you propose, either surgery or radiation? It doesn't make any sense to try to take them there. And survival is often used as a determinant as to whether a patient should be receive treatment. And what happened was that in the era of these newer systemic agents, the biologics and checkpoint inhibitors, we all of a sudden had extended survival for every single tumor histology. I think in the era of chemotherapy, we knew almost to the day how long somebody would survive. And then all of a sudden, for instance, for this, for melanoma, a single checkpoint inhibitor, nivolumab, more than tripled the survival compared to standard chemotherapy. And there are 8 other agents that are effective against melanoma. And we had no way to really judge that and integrate that into the decision of, does it make sense in the context of the disease with all their other illness, their other extended disease, to take them to surgery. This is a 20-year survival trend that was done at Memorial. And what we found was that there was a 20% improved survival over this 20-year period, which really reflected, again, this improvement in systemic disease control with these newer systemic agents. And while the Tomita and Takahashi scores were very effective in predicting survival before we had these agents, they really became somewhat antiquated in the era of these newer systemic agents. The Sorg nomogram and the New England Metastatic Spine Score were both developed post the development of these newer agents and are very good predictive models of whether a patient will be a less than 30-day survivor or will be alive for 5 years. And so I think these are available online. They were both developed in the Harvard system, and we did the validation on Sorg nomogram. When you really can't tell, you know, how long a patient, somebody's really pushing you to do something, the patient really looks sick, this may be a very effective way of trying to siphon out what's realistic in terms of whether you should take that patient to surgery or potentially radiation therapy. The other thing that's very interesting, and in part such a tribute to the system in Europe that came up with particularly the Samer-Comet trial, is for oligometastatic disease 1 to 5 metastases, that if in the Samer-Comet trial, they treated up to 1 to 5 metastases with either SBRT, stereotactic radiosurgery, versus conventional external beam radiation. And there was a significant survival advantage if they treated with SBRT in combination with best systemic therapy compared to conventional external beam radiation and best systemic therapy. So now you'll see a lot of times these asymptomatic small bone or liver lesions or lung lesions will get SBRT in order to try to impact the overall survival. The PISA trial was done at Memorial. It was a bone-only trial. 50% of those patients were spine tumors. And in that series, if we gave 24 gray single fraction, which we consider to be an ablative dose, we had better local control than at 9 gray times 3. But what was unexpected was that in the higher dose stereotactic radiosurgery, there's actually a decrease in distant metastases. So again, with this local radiation, we're beginning to impact systemic disease control, both decreasing distant metastases and increasing potentially overall survival. And that's a really meaningful integration of this technology. The rest of the talk, we're really going to talk about the combination on how we make decision in terms of neurologic and oncologic assessments. And again, from an oncologic perspective, to conventional external beam radiation, this 30 gray and 10 fractions, there are sensitive and moderately sensitive tumors, the hematologic malignancies, and then hormone-driven solid tumor like breast and prostate. The remainder of the solid tumors are largely radio-resistant to 30 gray and 10 fractions, including colon, non-small cell lung cancer, thyroid, renal, sarcoma, and melanoma. From a neurologic perspective, again, we're very concerned about myelopathy or a functional radiculopathy, but much of our decision-making is based on the degree of spinal cord compression based on that scoring system that I showed you earlier. So how do we make decisions, at least in 2022? Well, for the sensitive and moderately sensitive tumors, regardless of the degree of spinal cord compression in the absence of myelopathy, we're very comfortable putting them on high-dose steroids and then treating 30 gray and 10 fractions. For the moderately to highly resistant tumors with bone-only or epidural impingement, we've seen, again, very poor responses to conventional radiation. So those patients will typically go straight to stereotactic radiosurgery, either 24 gray single fraction or 24 to 30 gray in 3 fractions. And then for the moderately to highly resistant tumors with high-grade cord compression, we can't conform the beams tightly enough to spare spinal cord tolerance. So those patients, high-grade cord compression, moderately to highly resistant tumor, will go for this really simple separation surgery followed by radiosurgery to get local tumor control. What if we add myelopathy to the mix, that they actually come in with weakness or new onset sensory changes? It's really only the exquisitely sensitive tumors, the hematologic malignancies, that will put on high-dose steroids and take them to conventional radiation. Breast and prostate, you won't get a quick enough response to get recovery. And so for all radio-resistant tumors with high-grade cord compression myelopathy, we will take them for separation surgery followed by radiosurgery. And what about the patient who comes into your emergency room with an unknown tumor? They have no history of cancer and they come in with a newly diagnosed tumor and they're myelopathic. My recommendation is to you is just take them for separation surgery followed by radiosurgery. And it's really predicated on 2 issues. One is it's very hard to get a definitive diagnosis in a timely fashion that will give you confidence that it is, in point of fact, a truly radiosensitive tumor. So here was a patient of ours that came in. He has sclerotic bone disease, significant amount of soft tissue disease. This looks like lymphoma. We did a biopsy. The touch prep showed small blue cells that our pathologist, who we think are best in the world, said was consistent with lymphoma. And we gave the equivalent of conventional radiation, 20 gray and 5 fractions. 2 days later, the flow cytometry came back, and in point of fact, it was not lymphoma. And then the definitive diagnosis didn't come back for another 10 days, and it ended up being a neuroblastic tumor. And you can see what happened. If you're using radiation to get recovery of myelopathy, you actually have to have that tumor apoptose and decompress the spinal cord. And in point of fact, nothing happened to that tumor. Now, this patient happened not to be myelopathic, but we guessed wrong on the histology. And by the grace of goodness, they didn't progress over that 10-day period. But in point of fact, they had no response. So you can't get a definitive diagnosis in a short period of time, oftentimes with a frozen section or a touch prep. We have argued this for a long time. This has been a very big source of debate, especially in academic centers, is what's the chance that that patient who comes in myelopathic actually has chordoma, and you do separation surgery, this intralesional resection, and now you've ruined the chance to cure that patient. In point of fact, once you get this really large tumor, and especially in the epidural space, there's really no en bloc resection that's going to be meaningful to get a wide margin on this tumor, which is really critical in chordoma. This happened to be a football coach, so a very healthy guy, comes in, he's on a walker with severe lower extremity weakness and numbness, and came in with us. And our colleagues in Connecticut took them for simple separation surgery, and it ended up being chordoma. And again, there's a big argument about chordoma, whether you should wait for that diagnosis and then change your surgical strategy. Our philosophy is take them to surgery and get them out of trouble. And so they did that. We ended up taking them back for a reseparation surgery to get a bigger margin on the dura. And then we reconstructed with this dual rod construct and did a vascularized rib graft. Patient got 24 grade single fraction. Here's a 24-month follow-up with no evidence of residual or recurrent disease on standard MR or the DCE images. It turns out that you can give an ablative dose of radiation for chordoma. You can do it with protons, you can do it with carbon ions, and we can do it with high dose conformal photon stereotactic radiosurgery. And in our series of 35 patients, at a median dose of 24 gray single fraction, it didn't matter whether they got definitive radiation with no resection, whether they got an intralesional, either gross total or simple separation surgery, or got neoadjuvant followed by en bloc. The 5-year local recurrence-free survival is 90%. You can give an ablative dose of radiation. So don't stand on ceremony thinking, I'm going to wait on every single tumor with high-grade cord compression. The 1 in a million chance is going to be chordoma, because many of these patients can be salvaged. And I think it's a really disingenuous not to get somebody out of neurologic trouble with the ability to get them long-term control with radiation. The other problem is, while you're waiting for that definitive diagnosis to come in to make a decision about treatment, patients will often, once they're starting to get myelopathic, even in Asia D, will fall off the cliff very quickly. So a day or two later, even on high dose steroids, they'll go from a D to an A. You have a window of opportunity when they come in, particularly with a subtle myelopathy, to get them to treatment, to get them recovered. And so my sense is, if it comes in with an unknown primary, if it ends up being a really radiosensitive tumor, that's fine. You got them out of trouble. If it ends up being chordoma, you can salvage them. There's really not a great reason not to take somebody myelopathic and get neurologic recovery. So what do we know about radiosensitivity to that conventional radiation, 30 gray and 10? Well, it turns out there was very little in the literature that looked at differential radiosensitivity based on tumor histology. But what's there was remarkably consistent. There are those radiosensitive tumors, the hematologic malignancies, breast and prostate, with 2-year local control rates of 86%, versus the radio-resistant solid tumor malignancies with median durable responses of only 3 months and 2-year local control rates of 30%. Again, we can use conventional radiation for the really radiosensitive tumors. This is a patient with 3-level high-grade epidural spinal cord compression from known multiple myeloma, and you can see this really high-grade compression here. We put this patient on high-dose steroids, gave him 30 gray in 10 fractions, and you can see the tumor completely apoptosed, decompressing the spinal cord. You can't do better than that with surgery. So for the lymphoma, myeloma, you can treat with radiation therapy and get this kind of response. The problem is, you'll never see these responses in the radio-resistant tumors. And for that reason, patients with radio-resistant tumors with minimal or no spinal cord compression, where we have a target for radiation, we often will go straight to stereotactic radiosurgery. There is a plethora of data on good outcomes using radiosurgery. Here's our series of a little over 800 tumors, mostly for radio-resistant tumor histologies, where again, we had a target with an ESCC score 0 to 1C at a median follow-up of 2 years. Contours were according to Radiosurgery Consortium guidelines. The prescription dose was 18 to 26 gray single fraction, but dose was analyzed as a continuous variable. Optimal cut point was used to establish a low versus high dose cohort. The median dose planning target volume in the low dose group was 16.4 gray versus the high dose group was 22.4 gray. The only factor significant in the instance of local failure was a dose of radiation, but we still did great at a year in the low dose cohort, right, with a 5% failure rate versus less than 1% in the high dose cohort. Remember, this is compared to 70% recurrence rate using conventional external beam radiation. Where we start to fail in the low dose cohort is as we get out farther. So at 4 years, there's a 20% risk of failure versus the high dose cohort. Again, we're giving an ablative dose with a 2.1% failure rate. As you start to treat these tumors with patients living longer, and then tumors such as chordoma, that dose of radiation does mean something. What's most significant in this, though, is that these responses are completely histology independent. It doesn't matter if it's lymphoma, myeloma, breast, or prostate versus colon, non-small cell, thyroid. You overcome radioresistance with high dose per fraction radiation, and that becomes a game changer, including how we treat these tumors as a post-operative adjuvant. So how did it change our treatment paradigms from things like the Tomita and Takahashi score? Here's a patient with renal cell carcinoma, solitary metastases, ESCC 1B. The Tomita score was 4. The recommendation for this would be to en bloc resect this. This is long operating time, significant blood loss, And in many of these patients, they incur a significant morbidity, long hospital stays, and a delay in return to systemic therapy. With radiosurgery, obviously, the treatment times are very short. There's obviously no blood loss, but what we're getting, especially in that 24 gray single fraction group, is 98% local tumor control that is durable. And then the other side of it is we may, by the SABR-COMET trial and our PISA trial, also get a survival advantage and a decrease in distant metastases. Now, radiosurgery is not without complications, and we've worked really hard for the last 20 years to figure out what those complications were and how to mitigate them. The biggest risk is obviously to the spinal cord. And at a cord D max of 14 gray, we have less than a 1% chance of creating myelitis. The problem is that this D max of 14 gray is well below what we think we need to give an ablative dose of radiation. So it's that dose constraint on the spinal cord that prevents us from treating high-grade cord compression. Essentially, you would be underdosing at the margin of the cord where you need the greatest tumor control. So for patients with high-grade cord compression with radio-resistant tumors, we will most often take them for surgery, followed by radiation therapy. This is still largely predicated on the Patchell study, which was published in Lancet 2005. It's a prospective randomized trial of solid tumors looking at high-grade cord compression with myelopathy, but the myelopathy in that study could simply have been biologic back pain. It was comparing surgery and conventional external beam to conventional external beam alone. And very importantly, they excluded radiosensitive tumors, which would have heavily biased us towards the radiation arm. In every outcome variable, surgery was better than radiation therapy. And based on that and a number of other studies, the spinal oncology study group made a strong recommendation that patients with high-grade spinal cord compression due to solid tumor malignancy undergo surgical decompression stabilization followed by radiation therapy. The question became, right, what kind of surgery and what kind of radiation? With the integration of radiosurgery as a post-operative adjuvant, the surgical goals of spinal cord decompression for neurologic salvage and using screw rod systems to provide mechanical stability remain the same. What changed, right, is the oncology, how we achieve local tumor control. Again, it's completely predicated on the radiation response. So when we use conventional external beam radiation as a post-operative adjuvant, we often did maximally cytoreductive surgery. It was a rationale for doing a gross total resection or even en bloc. With the integration of radiosurgery, right, maybe the only goal has to be to reconstitute the thecal sac to create a better and safer target for ablative radiosurgery, and that became known as separation surgery. So here's an 86-year-old with papillary Asia C with this really high-grade cord compression and vertebral body involvement and 3-level vertebral body disease. And there's just no way that you're going to get an 86-year-old who's already myelopathic through a 3-level front-back surgery. Separation surgery is really simple. Traditionally, we instrumented 2 levels above and below the index level. We take a 3-millimeter matchstick burr and we drill off the lamina, superior and inferior facet joint, and pedicle flush to the vertebral body. We find normal dural planes and strip the tumor off of the dura, and ultimately you need to take out the PLL to affect the margin on the anterior dura. And what we're trying to do with separation surgery is not take out all the tumor. We're just trying to create a better target for radiation. So you can see this really high-grade compression here. All we did was reconstitute the thecal sac by taking tumor off of the dura, decompressing the dura and the spinal cord. We left all this tumor behind for radiation. We fused 2 levels above and below the index compression level. We took this patient to 8 grade times 3. She's fully ambulatory 2 years out. We gave her a surgery that she could tolerate, and then we got to effective radiation to get local tumor control. Why do we like separation surgery for metastatic disease? They're incredibly short operating times. Most of these surgeries, even for this really complicated multi-compartmental tumor, can be done in about 2.5 hours. You can do emergency operations for epidural tumors, and again, address these large multi-compartmental tumors with a significant reduction in morbidity by not having to take out all of this tumor. In many ways, we do a better and safer epidural decompression because when you come from the back, you can always find a normal dural margin and you're always stripping tumor from normal to abnormal, which is a really important concept. If you're coming from an anterior approach, you'd have to get through all this tumor to find the dura and pray that you find the dura before you're in the cord. If I start from the back, all I have to do is find normal dura here, and then I can strip this tumor off the dura and then take out the PLL to affect a margin anteriorly. And the biggest thing is it's the middle of the night, high-grade compression, they're myelopathic. You don't need an approach surgeon. And there's a significant reduction in this patient population by not having to go anterior transcavitary. You don't have to mobilize critical structures, which have often been irradiated previously. And then it avoids additional medical comorbidities. One of those places where it's pretty obvious that we want to avoid the anterior approach is really at the atlantoaxial junction. This was a patient of ours, 45-year-old, with a low-grade chondrosarcoma, circumferential bone disease. And the best approach to come for tumor at C1-2 is really a transmandibular osteotomy. So we open the jaw. Here's the hypoglossal nerve coming across that segment, and then here's a tumor deep to the this osteotomy. Here's a tongue which is pushed to the side, and then you have to do a posterior pharyngeal exposure and exposure in that area. The problem with this is when you do this, they have to be pegged and trached for at least 2 weeks after the surgery. And it was very in vogue at the time to put anterior cages, even though there's no load through the anterior column at C1-2. So we put a cage there, and that's 7 years we were looking through the mouth at the cage, and they had to have a full formal pharyngeal reconstruction. So the morbidity in this in a primary tumor population is big. Again, in the metastatic population, it's just not tolerated. Here's an example of a patient who came in, again, with an unknown primary. This is a 33-year-old who had had multiple operations for fibroids. She finally got pregnant. She was 3 months pregnant and tripped on a airplane jetway and actually became acutely quadriplegic. And again, no known history of cancer or tumor. And she had this massive tumor going into the posterior pharynx, and there was no way we were going to come anteriorly and split her jaw and try to get this tumor out. So we did a really simple separation surgery, did an epidural decompression, and then occipitocervical fixation. By the grace of goodness, she recovered to neurologically normal basically at a month. And so we did an effective decompression for neurologic salvage. It ended up being a low-grade leiomyosarcoma. So one of those fibroids that they took out actually had sarcoma that metastasized. At the time, we did not have a big experience treating sarcomas with stereotactic radiosurgery, but we used photon IGRT and gave her a sarcoma dose 66 gray and 33. We have a plethora of data now on sarcoma, and this probably would have gotten 3-fraction radiation if we were doing it today. But what's really compelling is at 3 months, the baby was delivered. She's now 14 years old. Here's the tumor that we left behind after the decompression. We gave that radiation. Here's the 14-year follow-up film with no evidence of residual recurrent tumor. It's not the amount of tumor you take out that's important. It's the dose of radiation, getting this effectively treated. We got her neurologic recovery and stabilized across that segment, and then relied on the radiation to get durable local tumor control. Taking out more tumor wouldn't have meant anything for her. And here, again, we're going back to that chordoma. This is a 54-year-old female. She's got a high cervical myelopathy with clumsy hand syndrome. You can see this really high-grade cord compression, bilateral vertebral artery involvement, and then this tumor extending into the posterior pharynx. The original plan was get her out of trouble. We would do separation surgery, radiation, and then the intent was to go back and resect the remainder of the tumor. So we took her for this really simple separation surgery with occipitocervical fixation. And again, all we did was reconstitute the thecal sac to create a better target for radiation. We left all this tumor behind. We gave her 24 gray single fraction. Here's the 7-year follow-up film with no evidence of residual recurrent tumor, right? We got her out of trouble. We got recovery of neurologic function, the myelopathy resolved. We stabilized across that segment, then we relied on the radiation, now given an ablative dose of radiation to control even chordoma. What's changed about separation surgery is that we traditionally went long segment with our fixation, minimum 2 above, 2 below with pedicle screws or lateral mass screws. And the rationale for that was that most patients are osteoporotic. And so we were trying to distribute the load. And then if they progress disease, it was also in an adjacent segment. More recently, we started, just like we do with the percutaneous stabilization for instability. In separation surgery, we're going short segment with PMMA augmented pedicle screws, single level above and below the decompressed level. In the long constructs, we had a failure rate of 2.8% that required a reoperation. And now with this short segment fixation, which we will think will continue to reduce the morbidity of the surgery, it's only 2.2% that requires a reoperation. So this has now become fairly standard. We go short segment, we overcome osteoporosis and adjacent segment progression with cement in those vertebral bodies. We're starting to, as much of Europe is, and so much credit to Dr. Meyer and the folks in Europe for developing these peak carbon fiber implants, which I think are going to be incredibly useful for cancer. It's definitely better for MR imaging for recurrence. And then for radiation, if you're doing MR CT simulation for photon radiation, or you're doing postoperative charged particle, proton beam or carbon ion, these are an absolute godsend, and they're starting to be integrated into our treatment paradigm with very, at least for us now, very specific indications, but I think they will get broader as time goes on. In terms of separation surgery, 75% of our non-ambulatory patients regain the ability to walk, and overall 90% are ambulatory. In terms of patient-reported outcomes, patients do significantly well in terms of pain recovery and general activity. How about in terms of tumor control? Well, there was really only one series that looked at surgery followed by conventional external beam radiation. It was Camp-Sammy, published in 1998. They did partial or complete resection, essentially very aggressive resection in 91% of patients, followed by conventional external beam radiation. The local control was only 30% of the year, and if you live long enough, basically everybody recurred. And the biggest predictor of recurrence rate was tumor histology. It didn't matter how aggressive you were with your surgery. If you're using suboptimal radiation, you're not going to get tumor control in the postoperative setting. Here's our original series of separation surgery followed by radiosurgery in 186 patients. Most were operated for high-grade cord compression with radio-resistant tumor histologies, and 50% had failed prior radiation, were being operated for progressive epidural disease and then required reirradiation. There were 3 dose strategies: high-dose single fraction, high-dose hypofractionated, and low-dose hypofractionated. The 1-year cumulative incidence of recurrence was 16%, but if we gave a high enough dose single fraction, 24 gray, or high-dose hypofractionated, 8 to 10 gray times 3, we had less than 10% recurrence at a year, and that appeared to be durable. And again, there's no association with radio-resistant tumor histologies. We overcome radio-resistance with high-dose per fraction radiation. Here's our more recent series of renal cell, again, considered an extraordinarily radio-resistant tumor to conventional radiation. The median dose was 27 gray in 3 fractions as a postoperative adjuvant. The 1-year cumulative incidence of recurrence was 4% and increased to 8% at 2 years. And again, remember, that's compared to 70% recurrence at a year using conventional radiation with aggressive surgery. And here's non-small cell lung cancer, again, a very aggressive radio-resistant tumor. At a median dose postoperatively of 27 gray in 3 fractions, and our 2-year cumulative incidence of recurrence is 5% with separation surgery followed by radiation. We looked at mutation status of these tumors to see if we could identify markers that would predict a good outcome, and it turned out that if you had an EGFR mutation but had never been exposed to an EGFR inhibitor, it was a 50% survival advantage. And you'll start to see this mutation status being integrated into these predictive models of survival as we get more data on these tumor-specific mutations. There's still lots of work to do. I think on the clinical side, we definitely are working to get as minimally invasive as we can. Some of that is going shorter segment with PERC screws, but we are starting to use tubular retractors for resection. There is a notion, which really doesn't apply to metastatic disease yet, that the Da Vinci robot is superbly qualified and an excellent technology for taking out paraspinal schwannomas, and we now have a series of about 30 or 35 of those. I did one the other day in the lumbosacral plexus, and from docking to out was 45 minutes. It really is an exquisite technology for that specific issue. In terms of our clinical research, a lot of it is now being predicated on combination therapy of radiation with either VEGF TKIs or checkpoint inhibitors. And then there's an enormous effort being made, again, to study these mutational status of these patients to see if we can impact and make better predictive models of survival and also impact their local tumor control and systemic disease control in a more meaningful way. So as it stands now, and again, this will change over time, in the NOMS framework, for patients with radiosensitive tumors, regardless of the degree of cord compression, we're very comfortable going to conventional external beam radiation. The exception is breast and prostate with myelopathy, who we take for separation surgery. If we have radio-resistant tumors with minimal or no spinal cord compression, where we have a target for radiation, we go straight to stereotactic radiosurgery. If a patient has radio-resistant tumor with high-grade cord compression, with or without myelopathy, we go for this really simple separation surgery followed by radiosurgery to get local tumor control. If they're unstable by the SINS criteria, they're not a candidate for radiation. They can be braced. We often will do kyphovertebroplasty, perc screws, or open surgery. And finally, everything is predicated on what makes sense in the context of the disease, how sick they are, based on any number of criteria. Now, I think many people are starting to use the SORG nomogram and the New England metastatic score to predict survival to see whether your intervention will be meaningful. And with that, I'll end. I hope that was meaningful, and any questions, I'm so happy to answer. Thank you.
Yeah, thank you very much, Mike. It was very meaningful. It was an impressive presentation showing us the present concept of metastatic spinal disease treatment and the importance as a game changer of stereotactic radiosurgery, which it nicely showed. We have several questions already in the Q&A box, and I have to sort this. But first of all, initially in your presentation, you mentioned that there's a certain subgroup of spinal mets of non-small cell lung cancer patients, which you tend to go for chemoradiation in a neoadjuvant setting before you go for surgery. Which are those combinations of which are those patients you would choose for this treatment type?
Florian, thanks so much for that. Yeah, it's really the Pancoast tumors that are stage 3B. So they're T4, N0, M0, the T4 being vertebral body or chest wall involvement at presentation. So they're not metastatic, they're primary lung with spine involvement. And there was an SWOG trial now many years ago that showed that if you gave upfront cisplatin with 60 gray conventional radiation, the survival of those patients, the 5-year survival went from 15 to 60%. It's still predicated on resecting that tumor. So you give neoadjuvant, and many of them have a histologic CR, and you still go back to resect that tumor for that percentage of patients that had a great response but still have microscopic residual. And it's really that population that you're trying to impact. And we used to just take them upfront surgery, and it was just a technical exercise, but it really wasn't so meaningful for them in terms of cure. And then all of a sudden, it was really Valerie Rush who started this protocol that they ran through a cooperative group. And so every Pancoast tumor that comes now that doesn't have metastatic disease will get upfront chemoradiation followed by en bloc resection.
Okay, thank you. Now, there's a question about the extent of separation surgery. The question is whether it can be done in multiple mets involving multiple levels. Maybe, Jen, can you just comment on what you can do and where the limits of separation surgery are in terms of how much of instrumentation you need? You mentioned you turn from the longer construct to the short constructs now. What is the limitation of how many levels would you do separating it, doing posterior wall resection?
Yeah, I think there's, within the last 3 weeks, we've done, for newly diagnosed high-grade core compression, we've done 3 or 4 levels. The glory of separation surgery is laminectomy is a much easier approach than multi-level vertebrectomy. So you can just continue your laminectomy to account for the levels of epidural disease, find normal dural planes, and then strip the tumor off. So it really, in that way, and again, all you're really trying to do is reconstitute the thecal sac to create a better target for radiation. And then, if they're myelopathic, you're also decompressing for neurologic salvage. So, I saw somebody yesterday that we did maybe 3 weeks ago who had 3 or 4 level epidural disease, but it's a really simple procedure to get them out of trouble and then get them to effective radiation. I think the thing we don't talk a lot about, the concept of separation surgery is give me a better target for radiation, but it was never really meant to say, if you want to take out the vertebral body from the behind, or, take out the vertebral body, nobody's telling you can't. If you want to slip a cage in the front, slip a cage in the front, but make sure, that it's compatible with the radiation that you're going to give. About 50% of the patients that we take for separation surgery, we reconstruct the anterior column with cement because it's easy. You can slip cement in like an open vertebroplasty, and we'll fill that defect and then compress it down. And it's a very effective strategy for these patients to give them the anterior column. It takes 10 minutes to put in, at the end of the resection. So if you want to do an anterior, it's fine. The problem a lot isn't so much the neurosurgeons doing this, who get the concept of decompression of the spinal cord. In the old days, particularly, it was the orthopedists who were much more interested in the bone, and they weren't actually reconstituting the thecal sac. So if they didn't give a decompression, they may not get neurologic recovery, but bigger time in the era of radiosurgery, we didn't have a target, right? Then we had to go back and re-decompress, which is really, so the focus of separation surgery is give me a target. Whatever else you want to do. If you want to do more, but at the end of the day, your goal is, reconstitute the thecal sac for neurologic salvage, and then give me a better target. Again, the instrumentation is not, it's neither here nor there. I think, for the posterior, if you want to use PEEK, use PEEK. If you want to use titanium and your radiation people can work with titanium, titanium is fine. For us, it just, everything we do is to try to reduce morbidity, time in the hospital, and then return to systemic therapy. So the vast majority of our patients, if they don't have other medical issues, are in the hospital for just that. For 3 days is probably the norm now, is probably the median. And then we do the simulation for radiation while they're in house. They go home for a week, and then between week 2 and 3, 10 days to 15 days, they get their radiation, and then we take out stitches at 3 weeks. It is a package deal, right? We never do separation surgery without the intent and the setup to do radiation as quickly as possible after the decompression. Because again, you can't predict the biology of these tumors. Some of these tumors will be back and worse. If you wait on prostate cancer, if you have high-grade core compression from prostate and you do separation surgery and you wait a month, it will be back and worse. And so there is this time element to get them to treatment when you use this strategy.
Yeah, okay. Then we have the question whether there's you see any indication for an angiography prior to surgery in a expected hemorrhagic spinal or highly vascularized spinal metastatic tumor, and which one you would pick for angiography prior to surgery?
Yeah, so embolization is really important for hypervascular tumors with this. One of the advantages of separation surgery is that you know where the dura is. So if you're tamponading bleeding, you're always pushing away from the dura. There's never a chance that you're pushing towards the spinal cord. That being said, there's a big hit list for preoperative embolization. The poster child is renal cell. The worst tumor is actually solitary fibrous tumor, which is hemangioparasitoma. So the rule of thumb is if the organ of origin is vascular, like thyroid, papillae and follicular thyroid are very vascular, kidneys very vascular, the tumor probably is too. And obviously if it has angio or hemangio in the name, it was named for that reason. That needs to be embolized. And it turns out that our blood loss in an embolized tumor, a hypervascular tumor versus a tumor that's not very vascular, like colon or non-small cell lung, there's no difference in blood loss if you have a good embolization. So it's critically important for separation surgery. And we just kind of took it out of the talk because it wasn't as interesting as some other stuff does, but absolutely, if you have a hypervascular tumor, embolize it pre-op.
Okay. Then we have a question about machine learning and the NOMS framework. Whether it has been used applications of machine learning for separation surgery, SRS as a component of the management protocol.
Not yet. I think we're working on that, particularly on the radiology side, using AI to figure out not so much for separation surgery or who's a candidate, but more for things like when you get a compression fracture, so the bone fractures down and then there's displacement. Is it actually progression of tumor, or is it just you displace tumor and it looks like you've progressed in the epidural space and it's, you know, treated? So I think we're starting to look at that, mostly AI for radiographic reads on these tumors. But you know, if anybody's interested and has a role for it, we're all in for sure. It just hasn't been big on our radar at the moment.
Yeah. Okay, then we got questions about two questions from the same person. The first one is it clear that in myelopathic patients with radioresistant tumor separation surgery is indicated? However, in asymptomatic mobile patients, could upfront SRB be non-inferior to separation surgery followed by SRS? Since those oncologic patients are often hesitant to undergo surgery when asymptomatic. But I think you showed that this is for protection of the spinal cord and to be able to get those patients to SRS.
Yeah, exactly. It's a brilliant question. I think, and your answer is exactly right. What has happened over time is we've gotten more aggressive with radiation, and we have data, particularly on the grade 2s with radioresistant tumor, that we can do 3-fraction radiation with local control of about 86%. So we give up a little bit of local tumor control, but we're going to spare a lot of patients surgery. You can definitely, you know, the problem with, if you have high grade compression, let's say a grade 3, really tight compression, no CSF seen, and you try to irradiate within the constraints of spinal cord tolerance, you are going to significantly underdose at the margin of the cord, and the probability is you're going to get progression. Can you do it? Of course you can do it. You know, you can just say, I'm only going to give, you know, 13 gray, or I'm going to do hypofractionated radiation, 27 gray in 3 fractions, 9 gray times 3, and I'm going to limit my cord dose to, you know, 22 gray, and we'll see what happens, right? We're never going to hurt the spinal cord, but we may get tumor progression, and that's always a viable option. It's not necessarily the best option, though, right? It's better if we can give them a better target with minimal surgery, then there's a much better chance of durable tumor control, but it's a trade-off, right? And if you're really sick, particularly, and you don't want surgery and you're not symptomatic, there are options, but the probability is that if you live long enough, you're probably going to progress and ultimately need surgery. And so we'd rather do it up front and get durable control.
Okay, and the second part of this person's question is, well, why not SRS for all patients, also for those patients with radiosensitive tumors, as it is still superior to the conventional radiation therapy?
We do. So breast and prostate will very often get SBRT. Myeloma and lymphoma are a little more, you know, we talk about them being radiosensitive, and if you have high grade and myelopathic, it's good. The converse is that a lot of those patients go straight to systemic, even with high grade and myelopathic, because those responses are also pretty quick and pretty durable. So we don't use SBRT a lot for myeloma, although we certainly can. There's no reason not to. I think the point more is the opposite, is you don't really want to use conventional for these truly radioresistant tumors, but there's nothing to prevent you from using it with the truly radiosensitive tumors.
Yeah. Okay. So what about those cases where you have a potentially unstable SIN score 7 to 12? How do you handle those cases?
Yeah, I think, you know, I think 7 to 12 is definitely a gray zone where we know that kyphovertebroplasty are meaningful in patients who are candidates. So if they have a significant amount of axial load movement related pain with a SINS of 7 to 12, the probability is we're going to offer them kyphovertebroplasty or percutaneous pedicle screws if they have post-element disease. They can be effectively braced now. The braces are much better than when we started. So a lot of our patients who aren't candidates for kyphovertebral, we will put in braces, but it's just the recognition that movement related pain, the 7 to 12, a lot of times, the question is whether if I irradiate that tumor, will their pain get better? And if it doesn't, and they have severe pain, then, in that 7 to 12 category, then it's really surgeon's judgment. It's patients, need to get out of pain and be able to function. And what we know about kyphovertebroplasty is you can take somebody, mostly we only really do it for severe pains. They have to be VAS 7 to 10, but you can take them from a 7 to a 10 in appropriately selected patients and make them a 3. And all of a sudden they're moving and they can walk and they can get out of bed. And so we never really deny anybody that if we think they can tolerate it and it will make their life better. We do close to 400 cement augmentations a year. So we believe in it. But if you see this patient population who, is crippled and then, the next day they're out of bed walking, the guy I showed was 84 years old with myeloma. And we did a 2-lever kyphoplasty thoracolumbar junction. It was the very first one. He could not roll over in bed. And the next day he was out. And 2 years later, he was asking to play, racquetball. And we said, no, we're not that good. But I mean, it gives them their life back. So 7 to 12, you can do a simple procedure, do it.
Yeah. Okay. Now, final question, remaining question is regarding chordomas, cervical chordomas, sacral chordomas. The question is, how do you biopsy those chordomas in order not to have a spread of the tumors? Do you go for open biopsies, needle biopsy, trocar guided needle biopsy, or what would you do in cervical versus sacral chordomas?
Yeah, I think, a coaxial biopsy needle where you pull the tumor through the needle through a tube is probably really important. In earnestness, I think it's probably less of an issue than we think it is in terms of spreading tumor. I mean, it definitely happens. I think you avoid the trans cavitary biopsies. So, transrectal, transoral, you can definitely pull tumor through and seed the mouth or the rectum. But it happens, but I think it's a pretty rare event. But I think if you're going to do it, use a coaxial biopsy needle that you can pull through a tube so that you don't, intentionally spread. We do a lot of separation surgery for these patients, and we don't really see seeding around there. And that may be because we cover that area with radiation, but it hasn't been a major issue.
Okay, great. So thank you, Mark. All questions are answered. Thank you for this very nice presentation. There's very, very interesting aspects and the good discussion afterwards. I think this was very educative for everybody here. No, this was it for this webinar. Next webinar will be on December 7 and will be announced by the EANS again. And for today, that's it. Thanks again.
Thanks, Floyd. Thank you.
Thank you for everybody who participated, and see you again on December 7. Thank you. Bye-bye.